Hi, good morning, good afternoon, and good evening, everyone. Welcome to the WHO EMRO NEDtP webinar series on institutionalization of evidence-informed policymaking for delivery for impact. My name is Mehnaz Khairandish. I am a regional advisor for evidence and data to policy at the WHO Regional Office for Eastern Mediterranean. It's my pleasure to welcome you all to the second session of our webinar series on evidence-informed policymaking. Today's session is focused on evidence synthesis and quality assessment in guideline development. And as we all know, development of high-quality evidence-based guidelines is crucial for ensuring effective healthcare policies and practices. Strong methodologies for evidence synthesis and quality assessment play a fundamental role in shaping robust, reliable, and in fact impactful guidelines that support decision makers in delivering better health outcomes. In this session, we will explore the importance of these processes, discuss the tools and methodologies and methods approaches used to ensure guideline credibility, and highlight best practices for strengthening the quality of evidence synthesis. This webinar series is part of our broader effort to strengthen institutionalized evidence-informed policymaking and to strengthen the institutional capacity for making policies based on evidence in the Eastern Mediterranean region. Our session today will be a 60-minute presentation, followed by a 20 minutes for question and answer and discussion session, where we do really encourage all participants to engage actively and share your comments and thoughts with us. We will then have a closing remarks from WHO EMRO leadership at the end of the session. Before we proceed, I would like to introduce our speakers for today's session. Our first speaker is Dr. Lubna Al-Ansari. Dr. Lubna Al-Ansari is a professor at King Saud University and an accomplished family physician specializing in chronic illnesses, geriatric medicine, and women's health. With over 30 years of experience, she has made significant contributions to evidence-based healthcare, clinical practice guidelines, and knowledge translation in Saudi Arabia, as well as on regional and international platforms. In addition to her academic and clinical roles, Dr. Lubna has served on Saudi Arabia's Consultative Council, making history as one of the first female members of the parliament. She also became the first Arab woman to serve as Assistant Director General for Health Metrics and Measurement at the WHO Health Organization. Our second speaker is Dr. Yasser Sami Amer. Dr. Yasser is a pediatrician and certified guideline methodologist at King Saud University. He is part of the steering committee at King Saud University Medical City and holds the evidence-based healthcare and knowledge translation research chair. For the past 15 years, Dr. Yasser has collaborated with teams to adapt, implement, digitize, and evaluate clinical practice guidelines, contributing to over 100 local, national, and international projects. He has also contributed to developing WHO guidelines, various capacity building and trainings initiatives, and publishing peer-reviewed articles and postgraduate theses. Dr. Yasser has been a member of Guideline International Network, and he is the chair of Genes Adaptation Working Group since 2021. Before we begin, I just want to go over a few guidelines for our online participation, please. Please use the question and answer or chat box to submit your questions and your comments. My colleague, Malika Tami, who is the Technical Officer for Evidence and Data to Policy in WHO EMRO, will check these boxes, and she will share those comments with us in the question and answer session. Please keep your microphones muted unless you're speaking, please. If you experience any technical difficulties, just inform us again through the chat box. We have Mr. Hanafi, our IT support, with us, and he will assist you as soon as possible. And also, I want to ask you to check the chat box once in a while, that where we will share our sources, relevant sources to evidence-informed policy making there with you. Please note that the session will be recorded, and it will be available on WHO website later. And with all these now, let me hand over to our first speaker, Dr. Lubna Al-Ansari, for her kind presentation. Dr. Lubna, over to you. Thank you.
Thank you very much, Dr. Mirnaz Kharandish, for this lovely introduction. And thank you very much for your all efforts, you under the leadership of Dr. Arash Rashidian and Dr. Hanan Balkhi, and the lovely team that you have in promoting evidence-informed policy making in the region. Your efforts are wonderful, and I'm sure that they will pay dividends in the short term, inshallah. I'm so happy to present this topic with my colleague, Dr. Yasser Amer. And in fact, our team has also participated one way or the other in creating this content. So, and I must say that it's the first time that I give a dual presentation, so bear with me if there are some hiccups here or there, but we hope that we will present something that is useful and to our audience and to especially decision makers and policy makers in the region. I guess it is part of our culture, the reference to evidence. Thank you again to all your efforts, and special thanks to Dr. Ghada Bawazir from our team, who has been with us. So we keep working together in so many aspects of evidence production, generation, implementation, and synthesis in terms of systematic reviews and guidelines. The outline of the presentation is as follows. I will start with an introduction on some definitions and the evolution of evidence-based medicine, systematic reviews, and clinical practice guidelines. And then we will, Yasser will kick off with highlighting on the technical aspects of evidence synthesis and the quality assessment dimensions of guideline development. And then I will come back with a focus on the bigger picture, the involvement of politics, policy, and international aspects, and then how to move on from evidence to the implementation part, which matters at the end to our patients and to our societies. Then we will highlight on some case studies and best practices from the region. And we'll conclude with the takeaways and future directions. And we hope that we would leave 30 to 40 minutes for Q&A and discussions. We are employed by King Saud University and its medical city. So the guideline steering committee that I chair, and Yasser is the co-chair of it, which has been working for over a decade now, and it has almost 2 decades, and it has produced so many guidelines at the level of the King Saud University and at the national level, as we will explain later on. But we have been involved with other entities nationally and internationally, which are involved in the development and implementation of guidelines. And I hope that we don't have any conflict of interest as far as this presentation is concerned. Now, when you search in PubMed about the term evidence-based medicine, and that search is a bit old, but I guess the message is clear, we will find that the first time that evidence-based medicine as a term appeared in the literature was in 1992. So it has been about 3 decades since the term has been coined, and it started to be used massively, as you can see with the timeline and the gradual increase in terms of hits that are referring to evidence-based medicine. And we tend to think of David Sackett as the father of EBM, but in fact, the first paper that appeared in 1992 was chaired by Gordon Guyat. David Sackett was one of the authors, and there are many names that you are possibly familiar with as leaders and pioneers in evidence-based medicine. Now, was this the beginning? And probably it wasn't, because there has been so many efforts to promote evidence-based medicine that I will highlight on in a minute. But the use of evidence, the use of this term, a little over 3 decades ago, was a kind of a response to large and unjustified variation in clinical practice, where sometimes in one region, different directorates will have different rates of procedures that are conducted. And it came as a response of significant levels of inappropriate care, and it as a response of evidence of over medicalization and over treatment for many health conditions that are possibly part of normal. So the evidence-based, the EBM, I'll call it for short, came as was regarded as a disruptive technology. It's a method where a new way of doing things, and it was I would say debating and challenging the previous practices that are well known. Oh, sorry. Okay, sorry. And it was radical in the sense that it challenged the standard practice that has been largely conducted and dictated in a way by the consultants and sometimes by policymakers. And it was a way to democratize decision-making by making research evidence available to everyone, and therefore making the decisions based on or at least informed by the evidence rather than just based on the experience. It was a way, or there has been evidence that there is a lot of healthcare waste, and this paper came in 2012, and it was describing the annual cost to the US healthcare system. It has a lot of waste, and this waste could be attributed to many causes, but in general, it was ranging with modeling, it was ranging between 21%, so 1/5, to about 1/2 of the spending on healthcare, which means that if these waste sources of inappropriate expenditure were catered for appropriately, possible, and we think that this could happen as a result of implementing evidence. Just imagine how much money could have been saved and invested in other aspects of healthcare. That pattern is still there, although we were talking about the previous paper as being published in 2012. Now, this is a recent paper that was published in 2022. And again, it showed that evidence-based practices improve patient outcomes and return on investment. These are the details. So at least half or 40% to 50% of all outcomes could have been improved if evidence-based modalities were implemented at the right time. But the waste is less, but it is still there. And then this paper with the editorial concluded that the authors estimate that the total amount of waste is around 760 billion to 930 billion US dollars in the US, and at least a quarter of that amount, which amounts to something like 200 billion US dollar, could be eliminated if evidence-based strategies to reduce this waste were scaled nationally. Now, I've just said that, and you all know that the term evidence-based medicine appeared in the literature in 1992. Is it something new? Probably the term is new. The formalization of the process is new in terms of the steps and the tools and the systems, technologies that are there to support the use of evidence are new, but the activities and the effort to make something that is really worthwhile for people, our people, is not new. There has always been effort to look for the best available evidence, research evidence, in order to improve the quality of care. And this is the timeline that shows some milestones. And the literature usually refer to James Lind as the conducting the first clinical trial, comparative trial, the famous one on vitamin C and scurvy. But it was from the director then of James Lind Alliance in the UK in Oxford, Sir Ian Chalmers, who told me that we think that James Lind was the first to conduct a comparative study and a trial by the standards that we know at the moment. But it was Arazi who was found to, in his writing, to include something about comparing the management of ascites, I guess, into using the conventional treatment versus not using it. And for that, he wanted to reach a conclusion, or ra'i, as it is in Arabic. And all this relates to documentation. So we can say that Arazi was the first to conduct a trial, but maybe in the previous civilizations and cultures, there has been other scientists and researchers who have conducted a comparison of treatment versus no treatment or versus other treatment, but that was not documented and we're not aware of. So that one aspect of how evidence-based medicine appeared as a term. In parallel to this was the power of systematic reviews. We think that systematic reviews might have been an outcome of evidence-based medicine. It has been improved a lot by the use of evidence by the EBM approach, but it appeared at the same time. In fact, I was attracted to evidence-based medicine because of the famous book by Ian Chalmers on systematic reviews, and that was in the mid-90s. So systematic reviews, we might say that the first one was in 1974, according to what we have in the literature. But it was in the 90s that the Cochrane collaboration was founded, and many powerful systematic reviews were published. And I'm sure that many of you are familiar with this review that was published, in fact, around the same time, a little before Goyat's paper in 1992, where they have tested a number of interventions in the field of cardiology for the management of myocardial infarction. And they have made the case that there were 35 trials that are published on the use of thrombolytics therapy, and they are giving conflicting results. Some are showing benefit, some are not showing benefit. But what they made is what the argument that they have made, that if somebody made the effort to do systematic reviews early on in the 70s, they could have shown, or that whoever has, oh my God, it could have been clearly it could have been clearly shown that thrombolytic therapy was effective. And what happened after that, from the 70s till the late 80s, is that we had more trials with more confidence, with shorter confidence, narrower confidence intervals, that thrombolytic therapy works. And you can imagine how much lives could have been saved, because it took them 2 decades in order to come to this conclusion. And the same for the use of beta blockers. post-MI, and many other examples in that pioneering paper. So the first decade of evidence-based medicine, although in that focused on the methodology in terms of the 5-step approach, the famous pyramid, the integration of experience with evidence and patients' contribution, but in that decade was the evolution of systematic reviews as well. And the last component that I'm talking about in the introduction is about guidelines. How old are clinical practice guidelines? And probably there has always been some guidance on what to do and how to do it in medical field. And they were available in the codes of Hammurabi, something like 400 BC, and they were available in the old pharaohs civilization. But the modern guidelines, as we know them, appeared about 100 years ago. An example is the CPR and the basic life support guidance and the guidance on vaccination. But all these guidance were largely what John Lewis referred to as GOPSAT. So it was more of a consensus or expert opinion rather than incorporating the evidence and using a rigorous methodology. Interestingly, we would find that in the first decade, many of the institutions that were involved with guidelines development, such as NICE, JBI, IHI, were founded in that decade as well. So things were going in parallel. And I wonder if it wasn't for these efforts on strengthening systematic reviews and guidelines and making them evidence-informed, I wonder if the movement of EBM could have lasted in the way that we know it at the moment. There were groups that, or entities that were there but couldn't continue, such as the National Guideline Clearinghouse and this group from Canada, from Ontario, which I've participated with them at one time, and I couldn't find a trace except for this article, commentary even, and it was led by Walter Roser, and it was about the use of an assessment tool that preceded the AGREE instrument, which was the CLUSO instrument, in terms of evaluating guidelines and making them ready for use. Anyway, so that was the first decade. The second decade, there were refining of, so the witnessed the evolution of another pyramid where there are, depending on the synthesis and the efforts to summarize and present the evidence, and more entities came into the field, such as Jen, Grade, and Kimball collaboration. Standards for guidelines, like those devised by what used to be called the Institute of Medicine then, which is the National Academies of Medicine, as well as the GEN standards that appear in 2012. And these are the items that these standards focused on. The WHO, although it was established as a normative organization, has produced many guidelines, but it was through the second decade, in the new millennium, that they were becoming more evidence-based, and there has been, with the development of the WHO handbook and the guidelines review committee, and the development of international collaborations to develop, to promote evidence into policy making, such as the EVIPNet. And the third decade, which we are, and probably we are into the moving into the fourth decade. The third decade focused on moving from the knowledge on how to overcome the knowledge to action gap, and there has been models such as the Canadian model, the Canadian Institute, and the evidence wheel from the JBI, the ecosystem, which was mapped as being fragmented and not communicated well with each other. All stakeholders, each one worked in silos. The ecosystem got refined and represented in a way that helps moving forwards and together. And then partnerships, many partnerships were developed in order to help into developing evidence and implementing it and impact evaluation, and that was reflected in conferences and in many of the, in fact, the last decade also witnessed revising and refining some of the concepts, like the old pyramid was as well questioned on whether it was reflecting what it was supposed to be reflecting, and how it can be better with the use of grade, the method for grading evidence, and making it more sophisticated and more useful for the current development of evidence-based guidelines. So the 3 decades helped in making an evidence-based approach like the new normal, and it became a way of life and a way of practicing healthcare. Dr. Yasser Amer will now focus on the technical aspects of evidence synthesis.
Thank you, Professor Lobna, for the introduction, and thank you for having me with you on this webinar. So I will focus on the technical aspects of evidence synthesis. So evidence synthesis has a pivotal role in the process of guideline development, whether it highlights the systematic collection and evaluation of research, or managing bias and ensuring the proper transparency and reproducibility of evidence. And proper evidence synthesis will lead to production of high quality evidence-based guidelines that will have a positive effect on patient outcomes and healthcare outcomes through standardizing care, reducing variability in treatment approaches, and improving patient outcomes by relying on high quality research, and empowering healthcare providers to make informed decisions, optimizing resource allocation and enhancing efficiency, and lastly, fostering a culture of continual improvement and evidence-based healthcare quality and safety. So we will find that evidence synthesis is one of the pivotal major steps in the production of guidelines, which has up till now four different approaches, whether guideline adoption or adaptation or contextualization, or de novo development or development. Evidence synthesis is mainly in the latter three approaches. And as highlighted by Prof. Lobna, the WHO Handbook of Guideline Development, the second edition that was released in 2014, again, we will find that clearly evidence synthesis is in the core steps of the guideline life cycle. And by the way, the WHO Handbook is currently under review for update with addition of new sections. And it is translated into one of the main languages of our region, which is in Arabic. So the definition of evidence synthesis it is a process of systematically gathering, analyzing, and summarizing findings from multiple studies on a specific healthcare topic. It provides a comprehensive understanding of the evidence and often used to inform decision-making in healthcare policy and research. And we will move through the key steps of evidence synthesis, which starts from formulating a healthcare question using the PICO model, the most famous model. There's other models like PCOTS or PIPO or PCAR, but PICO remains the most famous and standard model. Then followed by literature search and strategies, data extraction and syntheses, and identifying inclusion and exclusion criteria, and highlighting and documenting the websites or databases that were used for the search, for example, like PubMed or Cochrane or Embase, and there's others. Using mesh and Boolean characters, and never to neglect the gray literature and the unpublished data. One of the important issues I would like to shed some light on is the importance of involving and having within the guideline development team, medical and healthcare librarian, which is a specialty that we have found is quite scarce in our region. So the addition of a specialized librarian will contribute in expert searching, developing precise, comprehensive and search strategies, and specialized database navigation, including identifying key resources, gray literature retrieval through finding unpublished studies to reduce the bias, and reference management to organize the citations efficiently, and quality assurance, so ensuring rigor and transparency and reproducibility again. And finally, proper collaboration. It saves a lot of time to have a medical librarian within the team from our experience. So after the search and screening of evidence, part of the search that we search for published systematic review and finding high quality systematic reviews. So there are tools for assessing the quality of systematic reviews like AMSTAR 2, the second version, and ROBIS, which stands for Risk of Bias in Systematic Reviews. And there are other types of reviews like the scoping reviews, rapid reviews, and overviews, and of course, living reviews and others. Prisma is one of the, actually it is the main reporting checklist or reporting guidelines for reporting high quality systematic reviews. Prisma stands for Preferred Reporting Items for Systematic Review and Meta-Analyses. There is the newest 2020 version. It includes a standard flow chart and a checklist that is mostly requested by most of the peer-reviewed journals if you want to publish a high quality systematic review. And from the Equator Network, there are other reporting guidelines or reporting checklists for any type of study, whether RCTs or observational studies, and of course, clinical practice guidelines. And again, highlighting the grade system or grade approach. GRADE stands for Grading of Recommendations, Assessment, Development, and Evaluation. So the GRADE working group began in 2000, in the year 2000, as an informal collaboration of people interested in addressing the shortcomings of the different and discrepant grading systems in research for healthcare. So a common and sensible approach was developed to grade the quality or certainty of evidence and the strength of recommendations. That was adopted by a lot of international organizations like the WHO or NICE or CDC and so forth. We have 5 domains of the grade for appraising the quality of evidence or certainty of evidence, including the risk of bias, inconsistency of results, and directness of evidence, imprecision in results, and publication bias. And there are also different tools to assess the risk of bias in studies. For example, the Cochrane Risk of Bias version 2 for randomized controlled trials, and Robbins 1 for non-randomized studies. This is a nice figure of the grade system that was designed by Dr. Carlos Coelho Garcia. It shows the 5 domains that can downgrade the quality or certainty of evidence, and the 3 domains that can upgrade the quality or certainty of evidence. So the 5 domains, as we said, risk of bias, inconsistency, indirectness, and imprecision and publication bias, and the 3 that are used for upgrading the quality of evidence, if you start by non-randomized or observational studies, are the dose response and the large effect and opposing residual confounding factors. A standard grade evidence profile table has a lot of structures, including the study design, the effect size, and the 5 grade domains, and the final quality rating. And this is one example of a standard high quality grade evidence profile table. You can see all of the 5 domains of the appraising of the certainty of evidence and the effect, and at the end you will find the final conclusion and the quality of evidence. The grade book is an update of what was formerly known as the grade handbook, accessible from the Cochrane official website of the Cochrane collaboration. So the grade book was recently announced, and it is planned to replace the grade handbook by the year 2026 because it will include a lot of updates and new sections. It is available from the Grade Pro website. With the artificial intelligence revolution, we have also Grade GPT. So this chatbot was created by Ignacio Newman, and it will help in the process of the grade systematic reviews or grade guidelines. We have also the grade knowledge base that is provided by the Grade Pro, a lot of ready-made evidence to decision tables and evidence profiles are provided and accessible with a lot of other resources, very useful for systematic reviewers and guideline developers. So the process of making recommendations using grade will come up with two types of recommendations, either strong recommendations or weak or conditional recommendations. And there's a third category for good practice statements. So factors influencing the recommendation strength include benefits, a balance between the benefits and harms, and quality of evidence, and values and preferences, and resource use and feasibility. It is no longer, like Prof. Lobna explained, reliant on the old evidence pyramid that is only takes account for the type of study or the study design. As you can see, there are other factors. So the process or link from evidence to recommendations is called the evidence to decision framework, or short ETD. There are two famous examples: the WHO Integrate ETD framework that was published in 2019, and the GRADE ETD framework that was published in 2016. And there's a lot of updates for both versions. There are two main available softwares or online platforms to operationalize the grade system or the grade approach whether in conducting systematic reviews and evidence syntheses or in production of clinical practice guidelines or healthcare guidelines in general. There is the Grade Pro or the GDT that is available from the Grade Pro website, and there is the Magic app from the Magic Foundation website. Both will be, further explained in other sessions of these webinar series. Moving on to the guideline appraisal tools or quality assessment of guidelines. So why do we find till now that there is importance to conduct quality assessment or quality appraisals of guidelines? It still remains, and whether published or on official websites, that we find poor quality guidelines, and this will lead to ineffective or harmful medical practices, and again, to ensure that transparency and reducing bias in the guideline development process. There are 6 available guideline appraisal tools till now. We have the most widely cited AGREE-2 instrument, which stands for the Appraisal of Guidelines for Research and Evaluation. There is AGREE-2, and there is AGREE Global Reporting Scale, and there is another tool, AGREE-REX, which stands for Recommendation Excellence, that focuses on implementation. And there is also the AGREE-S, which focuses on surgical recommendations, but this is still in the validation process. Also, there's the ECAHI Guideline Quality Checklist that focuses on single appraisers. And we have the Panel View instrument that was produced by the GRADE Working Group.
Okay, after this close look at the micro level of how evidence is synthesized and how it can be evaluated and how it can be incorporated into guideline development, we probably need to have the big picture and look at the macro level of what can be done in order to make this available to societies, to our nations, and to our patients at large. How can we move from evidence to implementation? And the natural question is, do clinical practice guidelines lead to developing national health policies and strategies? Do we have an evidence that this happened? And there are many of the WHO guidelines that have led to national policies, thanks to all the efforts from the WHO people who have made this possible. But we need to keep in mind that evidence-based policy making is not a straightforward, if you consider that what was presented was a kind of being straightforward evidence-based approach and guideline development. It is more complicated and more sophisticated, and it's not only focused on evidence synthesis. In order to bring this evidence to the ground, there are so many other factors that need to be incorporated into the decision making. And new collaborations between scientists and policymakers are needed so that and here I'm wearing the hat of a researcher or an academic, we need to bring the evidence that is needed by policymakers. We need still to work on bridging the gap between research and policy or practice. That gap still exists, and we need to make efforts in order to make them working together. We need to invest more into capacity building, and I appreciate the efforts that are done by WHO EMRO, by Dr. Khirandish and Dr. Arash into making this possible, at least via an online self-paced course. We need to advocate for institutional and political support, and there are guidelines on how to develop that were produced by our hosts on how to develop national policies, and we need to work on overcoming the resistance from the professional societies and industry influences, and involve the advocacy groups, the NGOs and patient organizations in pushing for better guideline production. We need legitimacy, and that's what they did. Arash and Mernaz. But it has to be cascaded to the nations, to the countries, so that guidelines, evidence-based guidelines, and evidence-based evidence generation, and systematic reviews, and this set of products has to be encouraged by each country, and we need to have leadership. And the WHO has been taking the leadership at a global, at the headquarters, at a global scale, and the national. I'm so proud of this resolution that came out 5 or 6 years ago on the need to develop national institutional capacity for evidence-informed policy making. And it goes into all the details, and I'm sure that there will be, they are the people who would speak about this in a better way than me, but they have put a lot of thought into it, and these webinars are part of their plan for bringing and institutionalizing evidence-based policy making. And this is the regional action plan that has to be transformed into national action plans. I've noticed also that in PAHO, there are databases of evidence tables and health technology assessments reports that can be useful as well for many of us in the region. There are global coalitions, and one was published just a few months ago in Prague in the Global Evidence Summit. And we now have an evidence-based healthcare day. This one was the 4th, so it started 4 years ago. And the Guidelines International Network is doing a lot of effort in terms of supporting the development of guidelines and the evolution of guidelines methodologies. It has 16 working groups, and it has regional committees. One of them is the Arab regional community. And we have just met again in Prague last September, and we were honored by the presence of so many colleagues, but especially Dr. Arash Rashidian, because that in a way talks about the alliance of different institutions towards evidence-based policy making and evidence-based guidelines in the region. There have been an impact of the global and regional EBM initiatives in terms of improving outcomes, harmonization of guidelines, health equity, reduction in cost, and partnerships and coalitions. But that has largely been based despite the efforts to make it legitimate and institutionalized, that has been largely based on passion and volunteering and into making it a reality. So, and that is probably not enough. So there are challenges that are still available. And these challenges that are faced at a global level, I'll just go quickly through them. Variability in healthcare system, limited access to evidence, cultural and contextual differences, political and regulatory challenges, resistance to change, and the effort made to update the guidelines, the fragmented ecosystem, and the implementation and adherence challenges, sustainability, and technological barrier. When we focus specifically on the EMR or MENA region, MENA countries, and specifically on what challenges are there for evidence synthesis, we would highlight on that there are limited access to quality regional research. Yasser has just highlighted on the role of medical librarian, but I don't know if you're, as those of you who are involved in developing systematic reviews and guidelines would know how difficult in our region to get a medical librarian. And what we are doing at the moment is that we contact our friends, and if we have funds, then we pay. If we don't have funds, we don't. With colleagues in the JBI in Australia. There is a challenge related to the integration of real-world data, improving transparency in evidence appraisal, underrepresentation of our populations in the global research, variability in research capacity and data reporting in the different countries, and enhancing global collaboration in guideline development. And when we talk about guidelines, challenges facing guidelines, that has been covered in a paper that was published a couple of years ago by reviewing 61 guidelines produced by different countries in the region. And the main challenges were resistance to change, political instability, of course, and funding constraints, and the role of international organizations and donors in facilitating guidelines development. And in fact, the biggest test that we all have was COVID-19. That was the litmus test that the whole world and the region had. And there have been a lot of calls and description of that. It has been a big blow to evidence. We believe in evidence, but when it came to the reality, we didn't refer to evidence as we could have done this. So EBM still remain the elephant in the room, that we know it, but we don't talk about it, and we don't implement it. We choose other methods for action when we are under emergency or. So there has been a report, the independent panel that has been produced that has been initiated or established by the WHO, but it was independent, and it has another report that has been also came from the G20 high-level independent panel, and the Lancet Commission on the future of COVID-19 pandemic. They have all highlighted on the importance of referring to evidence. And if evidence is not available, evidence should be available for the future generations. For example, I was looking at some of the caricatures, jokes about the use of masks, and that where these jokes, and I haven't put them in my presentation, were from a book that was describing the Spanish flu 100 years ago. Now, we made the effort to review the physical interventions to interrupt or reduce the respiratory, the spread of respiratory viruses. And although that Cochrane review used to include all types of studies, and lately we decided that we will focus only on RCTs because they are the highest level of evidence in terms of design, and therefore the recent updates included RCTs only, and the latest one in 2022 included 78 trials, and it has shown that hand washing is effective. So we have no problem with hand washing. It has been shown to be effective in terms of interrupting or preventing the spread of the respiratory viruses. But when it comes to using masks, face masks, whether we're talking about the simple medical surgical masks or the N95, we're still not, there is no clear evidence, pooling of evidence that they do work. And just imagine 100 years later, in the when if God forbids there has been a huge pandemic, we go back to square one, and what we concluded with is that there is a need for large, well-designed RCTs to address the effectiveness of many of these interventions in multiple settings. Otherwise, and these are some of the reasons why, when it comes to the reality and creating rapid recommendations, sometimes people don't refer to evidence, because evidence has not been focusing on producing those pieces of information that policymakers need. Another paper that was carried out by Yasser and his colleagues that was evaluating clinical practice guidelines on the management of COVID in critical care, and it's a living systematic review, and it has been the commentary clear from the title that the case of COVID-19, low quality, rapid guidelines, and potential solutions. So it's the same problem. So when we are at leisure, relaxed, we are working on refining the methodologies, but we're not using them when we are supposed to be using them. And that has led to the Global Commission on Evidence that has been produced in 2000, a couple of years ago, and with an annual report and annual update. And there is a webinar by John Levis in this series, so I'll leave it for him and for his team to expand on it. But it's mainly talking about that there is global evidence that has to be produced that doesn't relate to a specific country or a population, but then there is a set of local guidelines that have to be produced in order to make this available at the national level and the regional level. Anyway, I'll skip that. They show me the evidence movement and what are the criteria of evidence that can be used. Again, I'm sure that it will be highlighted on in a better way in the future. We will end up by describing some of the case studies in our region, and I'll leave this to Yasser. The floor is yours. Sorry for taking time, but yeah.
Okay. So we have a lot of promising and successful case studies of national guideline projects and initiatives in the region. If we talk about GRADE guidelines or guideline initiatives, we have the famous American University of Beirut, the GRADE Center of the AOB in Lebanon. And there is the National Evidence-Based Medicine Center in Saudi Arabia, which is under the Saudi Health Council. And there is NES, which is the National Authority for Healthcare Quality in Tunisia. And regarding systematic reviews, we have some comprehensive centers that we'll be talking about.
Okay, so
this is the AOB GRADE Center, and they have recently published the Lebanese vitamin D guidelines, which uses the GRADE development methodology. This is the NEAS, or the National Authority for Health Evaluation and Accreditation in Tunisia, and also they have used a Tunisian development process, GRADE development process. This is the Saudi Arabian Saudi Health Council, which has the National Center for the Evidence-Based Practice. That had a lot of international collaborations. There was an earlier collaboration with McMaster University and a recent collaboration with the Clinical Solutions section of Elsevier. And they have came up with some lessons learned from that experience. And they have divided them into 4 main principles. So the recommendations came to produce high quality guidelines and to ensure comprehensive conflict of interest declaration. And there's a lot of currently available tools for managing conflict of interest. And there is identifying high priority topics for guidelines and the relevance to the local settings. And most importantly, regarding the sustainability of these guideline initiatives, which is one of the major challenges in our region, to build strategic partnerships and collaborations with relevant local, national, and regional bodies. This was one of the examples of the collaboration between the Saudi Health Council National Center for Evidence-Based Medicine and the King Saud University. And these were part of the meetings that were conducted. And an official MOU was signed in 2022, highlighting some activities in research and guideline production. So as far as guideline initiatives, we'll move to the systematic review and evidence initiatives. So we had the former Cochrane Bahrain that was established in 2015 and was closed in 2017. Back then, that was the only Cochrane Center in the region. And now we have the Cochrane Center, the Associate Center in Iran. And there's a recently brand new center that was launched last month in Pakistan. So we have a lot of promising and high quality initiatives in the region. This was a study we conducted a couple of years ago about mapping the different adaptation methodologies for guideline productions in the region. So it was obvious that a lot of guideline initiatives in the region will prefer guideline adaptation rather than de novo development. And we have identified 6 main methodologies for guideline adaptation that were used in the region: the ADAPTI and the CAN implement and adapted ADAPTI, and RAP ADAPTI, and Great Development and King Saud University modified ADAPTI. 2 of them were actually used and born in Saudi Arabia, which is the Great Development and the KSU modified ADAPTI. And one of them was born in Egypt, which is the adapted ADAPTI. This was the key paper for the Great Development methodology. And you can see here that it was developed as a result of establishing a new national guideline program by the MOH and King Saud University in collaboration with the McMaster University. This is our program in King Saud University Medical City, and this is our key article on the KSU modified ADAPTI methodology. The process follows the original ADAPTI in the 3 phases structure: the setup and adaptation and finalization. And we highlight the importance of linking the guideline production process with ongoing quality improvement cycles and the concept of the living guidelines as much as feasible. Our program has developed or adapted up till now 51 guidelines and 24 practice protocols, and another ongoing projects for guidelines and protocols, which are about 17. Our program has led to a scientific production of about 55 articles and more than 30 conference papers, whether nationally or internationally. These are some examples of the national guidelines that were produced in collaboration with our project. So there's the national guideline for ADHD in Saudi Arabia and the national guideline for autism spectrum disorder. We were very fortunate to be able to have an official job description within the King Saud University Medical City with the title of Guideline Methodologist or Methodologist for Clinical Practice Guidelines, which is a rare thing to have in the region. I mean, up till now, we have found guideline teams are getting hired with different titles like researchers, knowledge brokers, but the specific title of guideline methodologist is still quite difficult to have. We have conducted a huge amount of training and education sessions and capacity building throughout the years. We trained more than 1,700 staff from different ranks of healthcare providers. We have some successful guideline implementation outcomes. This is one example, the implementation of the venous thromboembolism prophylaxis clinical practice guideline. And it was found that the percentage of patients receiving the appropriate VT prophylaxis according to the adapted guideline recommendations increased by 39% over the years. We have a lot of regional and international collaborations, whether with the GIN, the Guidelines International Network. We have contributed and participated in the board of trustees, working groups, and regional communities. The establishment of the Arab GIN that was highlighted by Prof. Lubna is one of the greatest examples. We also participate in conference, scientific, and abstract review committees of GIN. We are a member of the WHO Guidelines Review Committee, and Prof. Lubna was the founder of the International Society for Evidence-Based Healthcare, and other collaborations, of course, with the WHO EMRO, including the capacity building activity with Tunisia back in 2015, and the National Guideline for chronic neck pain with Qatar, and the methodological support for national guidelines in Afghanistan. And there's other collaborations like the RIGHT Working Group or the GUIDE program and the GILA project and so forth.
Many thanks, Dr. Lubna and Dr. Yasser, for the great presentation. So we are a bit behind the schedule. Is there anything that you want to present, Dr. Lubna?
We have like maybe 3 minutes more, so we're about to finish. Yeah, we're probably over time, but these are the takeaways. And Yasser would like to emphasize on the importance of evidence synthesis as the foundation of guideline development. The use of tools and the competency in using them is essential, and we have to have a systematic decision-making process that is transparent. And future directions, we need more in-depth training in the region in terms of systematic reviews and guidelines development. We need a multi-sectoral approach and the involvement of policymakers, funders, international collaborations to advance evidence-based guideline development, and a call for action for more substantial institutional support and capacity building. And if we haven't started now, when we should have started. Thank you very much.
Thank you. Thank you so much, Dr. Lubna and Dr. Yasser, for the great presentation. Really, I mean, it's really appreciated you taking us through the history of evidence-based healthcare and the processes and key points for development and adaptation of guidelines to the national context and national needs. So it was great to hear from the tools and approaches which can support and ensure the efficient evidence-informed policy making. So now we are a bit behind schedule. So I would like to ask Malika, please share any comments and questions if has been shared by colleagues.
Sure, thank you. So we have one question from Dr. Abdullah bin Good from Yemen. He's asking, is there any online training short course about systematic review and meta-analysis?
Well, there are many courses, and we have conducted some courses. We haven't done an online course yet, but we are working on that. So we'll share this. And I've seen, I think you have put, Dr. Mary, she has put the link for your courses as well. So we are investing in capacity building. In fact, for systematic reviews. In fact, we are trying now to teach undergraduate students and postgraduate students to grow medically or clinically and research-wise in terms of believing in evidence and having the capacity for developing systematic reviews. That was a lesson that I've learned from I forgot his name, was a Syrian colleague who was doing it in the field of psychiatry, maybe decades, 1 or 2 decades ago. Adib Asali, yes. So there is a lot, and the students are doing a better job. I wouldn't say a better job, but a faster job, and they are doing of high quality. So we need to invest in the future generations to have a stronger evidence-based movement.
Thank you, Dr. Lubna. Thanks, Dr. Bingut, for asking this question. I also put on the chat box, but I also want to mention that there is a web-based training package which is developed by WHO EMRO. The link is in the chat box. In this training package, all trainings, which are offline, online courses, and also workshops, short, long ones that, they are all publicly available free of charge from different sources all around the world, are gathered in this training package. And there are boxes which is for evidence synthesis, which is for systematic review and meta-analysis. Please, I really encourage you all to go and check this training package. And this package has been updated every 6 months. So I do really encourage you to check it every 6 months. I mean, once in a while that every new material is available, we usually go and find it and update our training package accordingly. So is there any question? So because maybe we can take only one comment, Malika, then we go to the closing remarks session. Thank you.
Yes, we just received one question from Dr. Fakr Alayubi. He's asking, what is the limitation you're facing? Do you think it's different from other regions around the world?
Maybe in 1 minute, Dr. Lubna, and this is the question that I want to hear from Dr. Arash for his also reflection. 1 minute, Dr. Lubna, 1 minute, Dr. Arash, please. Thank you.
Of course, our region is one of the most challenging and difficult regions to manage because of the variety. We don't lack the manpower, I guess. Even if we lack them, it's not difficult to generate the capacities that are needed for evidence synthesis. But the instability and the attitude of working together that we are overcoming at the moment has been a barrier. And there are many others that I've just presented in my presentation. I'll leave the floor for Dr. Arash.
Many thanks. I mean, just to add briefly on this, the point is, directly to this question, the methodological challenges, resource challenges, and also the issues of how to address on a priority as with the recommendation, they appear everywhere. It's not just in our region, countries of the region. The shape of it might differ even from one institution to another institution in a certain country, or for one program to another program in one country for a national guideline. But what is probably different, I would say, and this is very much relevant to what Lubna and Yasser also were highlighting several times, is that we do not have enough between country collaboration in the region. And that I would say compared to, let's say, Americas, or compared to many programs in Europe, and even sometimes to Africa, that the institutions have more traditions of working together, multi-country work. That's the thing we are trying and hoping that to overcome further in the region. And part of that is also related to the network that is behind this seminar series. I mean, NEDtP, which is a network of institutions. Right now, there are 34 or 35 institutions from the region. And if your institution is interested, including Kingstown University, part of the network. And if your institution, I'm talking to colleagues on the call, is interested to join the network, just get in touch with Dr. Khair and Ms. Tamim, who are on the call, and colleagues will be more than happy to get to that. So I stop here, Mehnaz. I know you are behind the time, but do you wish to move to the next element, or tell me what to do?
Thank you, Dr. Arash. Thank you, colleagues, for sharing your comments. Now, with your permission, I want to invite Dr. Arash Rashidian, our Director for Science Information Dissemination in the WHO Regional Office for Eastern Mediterranean, who is the leader of the agenda for evidence-informed policymaking in the region, for his kind closing remarks. Dr. Arash, over to you. Thank you.
Many thanks indeed. I'm very grateful to dear colleagues, dear friends, Lubna and Yasser, and your work in the region in areas of guideline is phenomenal. I mean, what you have contributed, also the work you do with the GIN program globally, with Guideline International Network. I mean, that's impressive. I mean, the work, also the support that you provided the WHO agenda as we go forward. Also, I want to acknowledge that. And the presentation was also in line with all of those. Obviously, I mean, I know you as friends as well for many years. With Lubna goes over 25 years now. So in a way, that history is also related to the programs as go forward, and that those are the things that will help us to use resources better and when we communicate. What I want to highlight as a sort of maybe take-home message, as Dr. Kharanjish kindly requested as the next step. So when we talk of guideline adaptation, adapting a guideline to a national context, that means there is a good guideline somewhere else, that you're going to use it instead of starting from scratch. The main purpose of doing that is that we don't want to waste resources in the process. I mean, Lubna mentioned that guidelines help us to reduce waste in the practice of services in the health sector. But guideline development itself is also costly and would require a lot of technical resources, etc. So, and it takes time as well, more importantly, when there is a priority countries want to apply. But then, so that means the methodology should be robust and valid. Adaptation is not just we sit together and saying that, oh, well, let's do it like this in our region or in our country, because we don't have that, we do have the other option. It needs looking at evidence, global evidence sometimes, but mostly national evidence. It needs agreement between stakeholders. All of them are needed. But the process of adaptation itself should remain simple. Otherwise, the main purpose of it is not achieved. There are some adaptation recommendations. They actually become so complicated that the teams might say, well, we rather to do the guideline from scratch rather than going through all those processes for adaptation of everything else that others have said. That has been the main issue. And these are the messages also we heard from colleagues. And the other thing is about the process at national level. So it's not just about technically making sure the guideline is relevant to the context. It's also ensuring that the national process to make that a national guideline is in place. How the stakeholders are playing together and how they bring them together. They agree on the same advice. So let's say in countries of the region, private sector is a bigger provider of services, academic institutions, they provide services, public sector, hospitals and services, primary care, etc. There are military-based related medical care, healthcare processes. When we talk of a national guideline, all of this should be in the same place. All of them should agree with each other. And that means also sort of establishing those processes. And the handbook that we refer to in the chat is trying to also provide some guidance on how to do that in a national context. And lastly, all of this, as Lubna also used one of the slides about the sort of disparities within the agenda, is about national institutional capacity for evidence-informed policymaking. Guideline is one piece of the puzzle. It needs to be linked better with HTA, Health Technology Assessment Program. It needs to be better linked with the sort of other policymaking processes using national data, and also knowledge translation processes as well. So with that, I stop here, and it's our pleasure to host dear colleagues. I'm very grateful to you, and very grateful to our participants, and also extremely grateful to my colleagues, Dr. Mehnaz Kharanjish, Ms. Malika Tamim, Mr. Mahmoud, and other colleagues that Ms. Hala, that have made this seminar possible. Thank you.
We appreciate your efforts in promoting this in the region. And it is flourishing, and it will be better and better, inshallah.
Thank you so much. Thank you for being with us. Please join us in our next session, which is on 22nd of April. I hope that we will see you in that session as well. Thank you to the speakers, Dr. Arash, Malika, Mahmoud, and everyone. Thank you. Bye-bye.